We may have some overlap between what I'm going to present and Matt and I are going to work that out. No dueling, but like we're going to skip some of our slides. Why is that like that? Am I in a wrong format or something? You see how it's cut off? Yeah, okay. I just put this up here because I wanted you guys to see that the nerves are very important, right? And you can see how these migratory complexes, when they start through the myenteric plexus and the interstitial cells of Cajal, that's what I say, but apparently other people say it differently, so we'll figure it out. I'm not sure. We'll ask Jeff over there how he says it from down under. All right, and now, so this was just important for you to see because part of when we talk about etiology, we're going to get into some of the myenteric plexus. So it is a chronic symptomatic disorder, as you just heard. How wonderful that she presented that, because I think many times, you know, the gastroparesis patients are difficult to deal with because our ability to help them is not as good as it should be. So delayed emptying without evidence of mechanical obstruction, and the most common causes are obviously diabetes. That is a non-people first. I have to change that. It's diabetes, post-surgical, and also idiopathic. So idiopathic gastroparesis is obviously not from diabetes, not related to other gastric surgery, but more importantly, not due to any medications that are taking, like opiates or anticholinergics, and now also all those GLP-1 receptor agonists and their dual and tripeptides. And this is a breakdown of gastroparesis. So 36% of patients have idiopathic, 29% from diabetes, and then you see the breakdown further, but you can also see it obviously after gastric surgery, but also 7.5% in Parkinson's, collagen vascular disorders, and then some miscellaneous causes as well. Unfortunately, this is yet again another disease that affects women in greater predilection than men. Sorry, I just had to throw that in there. But it's irrespective, the ratio is the same irrespective of the etiology, and gastroparesis per 100,000 person years was 9.8 for women, 2.4 for men. This was from a Minnesota database. I actually got a lot of information, particularly from this Gastroenterological Clinics of North America chapter, and its incidence approaches 2% of the general population, which is pretty high. It can be, this is why I asked about the prodrome. You can have a viral syndrome, and this can show up after, related to viral injury of the nerves, or the ICC. Post-viral gastroparesis was detected in 23% of patients in this study, and then the symptoms, as she mentioned, are nausea, vomiting, diarrhea, of the viral illness, but then you see nausea, vomiting, early satiety, and if it persisted for more than 3 months with a delay in gastric emptying. And the major viruses that were suspected are cytomegalovirus, Epstein-Barr, and herpes varicella. So this is looking at the histology. Is this, are you going to talk about this, Matt? Okay, perfect. We're such a team, just telling you. And so this was done on 40 patients, and what they found were loss of interstitial cells, of however you want to say it, and also some showing injury or an abnormal immune infiltrate, which had macrophages, excuse me, and decreased nerve fibers. So also there's this whole thing about nitric oxide synthase expression and how it was decreased in the patients with idiopathic versus patients with diabetes, and that's the neuronal version of that. And on electron microscopy, there was a markedly increased connective tissue stroma that was present in both idiopathic and also that with gastroparesis of diabetes. And then lastly, there was a loss of KIT expression, which suggested a loss of those interstitial cells of Cajal. And you saw this more with the in diabetes. There was significant correlation with enteric nerves, but not in idiopathic. And if you just saw this, though, it did not correlate with symptom severity, and overall clinical severity, and nausea was associated with a in idiopathic, you saw this infiltrate around the myenteric plexus. Anyone know what these are? Yeah, whippets. I never did them. Maybe once, college, okay? But I was like, I would put in whippets. I'm like, I don't even remember this, but okay. So, but when you look at molecular findings, then again, you're looking at that nitric oxide synthase expression. And so this is going to ultimately inform, based on a molecular level, how we could possibly treat it because of putative targets. And then this is this is a study that showed that problem with the gastric enteric nervous system, where there's increased fibrosis in the muscle layers and significant reduction in the neuronal nitric oxide synthase, as well as some other hormones. So the drugs that can generally do this are opioids, anticholinergics, but now we have SGLT2s and all the forms of GLP-1 receptor agonists. And this is just going to show you that, bottom line here, over 3.5 times more likely to experience gastroparesis if you're taking a GLP-1. 9 times. This study showed a 9-time elevated risk for pancreatitis, although we heard at the Gerald Marks lecture that that's not really that common. And this is one of the receptors that's really attractive for as a therapeutic target, and we don't currently have the drugs or anything like that, but it's supposed to be helping not just with gastroparesis, but irritable bowel syndrome as well, and Alzheimer's disease. That's what AD is. And so just to summarize, I'd say if you look at the etiology, it's complicated. Maybe there's going to be some potential drug treatments, and we'll hear about that later. And understanding the pathophysiology has not moved treatment as quickly as it ought, because we are seeing all these things on histology. We're getting these findings for nitric oxide synthase, and yet we haven't been able to come up with a drug treatment. And as you heard from Matt's patient, even the surgeries are hard to improve all of the symptomatology. We make it better, but we don't cure it. Thank you.